Welcome to the Piedmont Napa Valley Cardiology Conference 2018. My name is Prashant Kaul. I'm an interventional cardiologist at the Piedmont Heart Institute in Atlanta, Georgia. I'm here with my very good friends and colleagues, Anna Klinich and Jeffrey Marshall, and we're just going to be discussing the Detroit Cardiogenic Shock Initiative. So Anna, tell us a little bit about the initiative started by the group up there and what the goals of the initiative is.
There's been minimal change in cardiac mortality over the last 30 years in the treatment of cardiogenic shock. And Dr. Bill O'Neill from Henry Ford Hospital and other investigators from 3 other institutions have tried to analyze the registry data from the Impella Abiomed company and try to determine what it was in certain institutions that improved the mortality from 20% in some centers to up to 80%. And they found several variables that good institutions did. They included things such as placing an Impella device pre-PCI, instituting hemodynamic monitoring, and then using things such as the cardiac power output to assess left ventricular function and the PAPI, or pulmonary pulsatility index, to assess RV function, and using the data for that in the cath lab and afterwards to try to minimize pressor and inotrope use, and found that by doing this in a systematic way, they could really impact on the mortality of their patients.
Great, thank you. So Jeff, your group up in Northeast Georgia have become part of this initiative. So tell us a little bit about your experiences with the logistics of the initiative and your experiences being part of this.
So thanks for having us here. And actually, one of my partners, Allison DuPont, is actually the PI of the national shock trial run by Bill and Baber Basir up in Detroit. And basically what we're doing is bringing those people to the lab and trying to reduce the door to support time. So everybody gets hemodynamic monitoring, like Anna said, but then we're trying to get them on support as fast as possible. Now logistically, that's a big deal because there's state involvement. You know, the ambulance services are owned by the counties, and they direct where these patients go. So I think a more important thing, or as important, is the ACC AHA shock scientific statement put out last November. I think we need to shift to big centers that do this well, having patients really directed to those places. I think that's as important as door to unload time.
Now you kind of alluded to the logistics of this a little bit, but you know, we have this problem with STEMI trials and any trials where patients are coming in emergency situations. So how have you guys dealt with informed consent in patients who are in the throes of cardiogenic shock when it comes to this?
Yeah, and those are kind of difficult things, but it's really implied emergency consent is what we've done, and that's gone through. We use Western IRB, but basically, if somebody comes in and they're dying, we're assuming they're giving us consent to help them, unless of course they're we know before time that they're DNRs or something like that. The harder part is really working it out with the ambulance services. Where should those people really go? And I think that's going to be a difficult thing in every state, and it's going to be a statewide solution.
And is your vision to have a statewide network of hospitals that provide this service, or what is the ultimate aim here?
So actually in Georgia, we passed a state law. It's the Emergency Cardiac Care Law that provides for 3 levels of care. Level 1 care is the top level of care that has open heart surgery, can do ECMO, can do Impella, can do ventricular support. Level 2 is really a seaport level hospital that can do angioplasty but doesn't have full support. And then level 3 is a place that doesn't have angioplasty that should transfer patients as fast as possible. The rubber meets the road as to what that transport time should be. And there are actually suggestions in the AHA-ACC scientific paper about how long that should be. It's not been tested, but there are data to support some of that, and that's going to be the hard part.
I was just going to add one thing, that at Piedmont now, we have had one of our cardiac surgeons occasionally go with a perfusionist and staff in a mobile unit to an outside facility that does not have PCI capability, cannulate a patient and bring the patient back. So that's one of the things we're trying to do at
Big and
Piedmont.
Fantastic. Yeah.